Good morning, everybody, and thank you, Chairs, for adding us to the programme. So this is a talk about the patients whose voices we seldom hear. I also think it's a talk about a paradox in our services, in that those who we know have liver disease who are most likely to get HCC are the least likely to engage effectively with HCC surveillance. The only disclosure I have is to say that what I'm talking about this morning is a massive team effort. I'm immensely grateful to the team in Portsmouth, Bournemouth, Southampton, the HCC Trust, and Mukti and her team at NHS England, who've kindly funded this pilot for the first 12 months. Just to give you a little bit of context about what I'm talking about. So this is a schematic from a recent publication that was adapted by one of our MSc students locally that kind of outlines the social determinants that underpin inequalities in liver health and specifically orientated towards the inequalities in HCC incidence and outcomes. And the focus of the HELIXA programme was on the way in which we organise our healthcare to try and overcome some of these social determinants of outcomes of HCC. Healthcare access has been defined by others alongside behavioural factors as a midstream determinant of health inequalities in liver health. And as you can see from this graph here, patients from underserved and more deprived populations are likely to develop incident liver disease earlier. They're likely to have delays in their diagnostic pathway. They're likely to develop incident complications earlier and therefore have a higher overall mortality. And this represents a social epidemiological gap that exists within our societies. So what am I actually talking about today? So the aim of the HELIXA programme was to design and implement an enhanced liver care pathway to increase the engagement of underserved people living with cirrhosis into HCC surveillance. And it's been run in three large trusts in Wessex, Southampton, Bournemouth and Portsmouth, and initially received 12 months of funding from NHS England. We had a really wide eligibility criteria for patients to be added to the programme. So basically it was sort of anyone who you thought was likely not to engage well with HCC surveillance in your practice. So if that could be someone who'd just been given a new diagnosis of liver cirrhosis who needed HCC surveillance and you had significant doubts about whether or not they'd attend for a 6-monthly ultrasound scan. It could be somebody who just DNA'd an ultrasound appointment and looking at their record it looked like they were unlikely to attend reliably follow-up appointments. Or it could be somebody who was found to be fallen way outside of ultrasound surveillance when the team in that particular trust did a look back retrospectively at their cirrhotic caseload to see who was actively engaging. Just to add a little bit of colour to this talk, so this is a completely anonymised representation, I suppose, of a case who was added to the programme. So this is Bill. At the point he was added to the programme, he was in his early 60s. He had a history of harmful alcohol consumption that was ongoing. He had liver cirrhosis, and he actually had a lesion in his liver that had been seen on ultrasound scan. And he previously engaged with HCV treatment and had been successfully treated for hepatitis C. But as you can see from this kind of track record of his engagement since 2007, he'd had many occasions where he'd not engaged effectively with care for whatever reason. And in fact, over 16 years, he'd failed to attend, in inverted commas, 25 outpatient appointments, 7 MRI scans, and numerous liver ultrasound scans. And no one, interestingly, in the notes had ever actually documented why. So that's Bill, and we'll come back to him in a minute. I'll just talk you through what the programme actually looks like. So step one of the programme was to use HCC navigators, which we just heard about, to identify patients who were falling outside of surveillance, add them to the HELIXA programme, and then kind of make first contact. And that could be something really simple like rebooking the appointment, changing the appointment location, or just sending them a reminder on the day. And then the second level of support was that navigator would then offer the individual peer supports, which we called liver health champions in the community, if that person, they felt that even with the navigator level input, was going to struggle to engage with the program. And that tier 2 support, really kind of intensive support, was usually face-to-face. It was usually conducted in the community, and our liver health champions actually went and met the people, as Tanya, our lead champion, calls it, where they were at. And that could include education, company, just sort of reassurance, sort of navigating the hospital, and sometimes actual sort of direct help travelling to the scan on the day. So the programme had a lot of moving parts, and we did not have much time. So we had navigators to appoint within the 3 trusts, and we did manage to get that done within about 6 to 8 months of the programme starting. We then had to write the job descriptions and advertise the jobs for our liver health champions or peers who are working in the community, and then interview and appoint those roles. So it wasn't until July 2023, after originally getting the kind of award of, or the letter telling us we were going to get the money in March 2022, that the programme was fully operational. And today I'm just going to share with you just the first 9 months of what we managed to achieve. So in 2 of the trusts, there's still an information governance barrier in the third, but in 2 of the trusts we added 300 patients who had known liver cirrhosis to the programme who had fallen outside of HCC surveillance or were very likely to fall outside of surveillance after diagnosis. 200 of these were able to be contacted by the HCC navigators. Almost all of these underwent a scan in the first 6 months. Obviously, the sustainability of the programme is crucial to its future effectiveness. And about a third of those that had a scan only got there with that high-level, intense peer-level support within the community. Who needed the programme? So they're relatively old, so they're 56. The most were male, which isn't on this slide. They were mostly, as is typical of Wessex, white and British, with the largest minority group being those of Eastern European background. Most had alcohol-related liver disease, with hepatitis C being a close second. Most had been diagnosed many years before, and on average they'd missed at least 2 liver ultrasounds, with the maximum having missed 16 liver ultrasounds. So what did the programme do for Bill? So in short, he turned up for the first time consistently in many, many years. That included an MRI scan, included outpatient appointments face-to-face, it's included telephone appointments, it's also included varicose surveillance, and interestingly, it has now included an community alcohol detox programme, which is the first time he's ever managed to access that. And a big concern that the community practitioners had was actually the state of his liver, and our champions have managed to kind of mediate between us and the community alcohol services. So I guess the effect was more than we had initially intended. So Helixa has been funded for another year by NHS England. We're appointing as part of that a dedicated project manager, and there is potential to expand within the region. However, it is expensive. The peers, and we very much borrowed this from the hepatitis C programme, are not cheap, and there is no demonstration of cost effectiveness or evidence of effectiveness against a controlled population. And so can we justify long-term funding? This is something we're looking at. So Southampton's run one of the NIHR collaboration grants. So I've met many of you as part of that across over the last year in trying to put together a kind of the landscape to conduct research in this space. And in November of this year, we're going to apply for a mixed methods evaluation to the NIHR HS and DR programme as part of the liver call that I know many of you are aware of. Acknowledgements again, and then questions.